can help WMNF now and into the future by donating gifts of stock, real estate, retirement assets, or a life insurance policy. It's easy to leave a legacy of love. Just call 813-238-8001 or go to WMNF.org/plannedgiving to get started today.
Welcome to Tuesday Cafe. I'm Sean Canan. We're broadcasting live on May 13th from the studios of WMNF in Tampa. During May, WMNF's mission focus is on mental health. So this hour on Tuesday Cafe, we're bringing you a special program. It's called The Aging Mind. It explores the unique mental health challenges of older adults, as well as improved treatment systems. So here is The Aging Mind on WMNF Tampa.
You're listening to The Aging Mind, a broadcast special from Call to Mind, American Public Media's initiative to foster new conversations about mental health. I'm Kimberly Adams. America is aging. There are almost 56 million Americans over the age of 65 years old, which is about 17% of the population. And that number will double over the coming decades. Aging, of course, brings health challenges. But while most people might worry about familiar issues like balance, cognition, and physical strength, about a quarter of older adults also live with a mental illness, like depression, anxiety, or substance use disorders. While some of these folks have been managing for years, others develop new mental health conditions as they age. Either way, these days, more Americans are living with mental illnesses, and only about half of them get the treatment they need. Older folks are often overlooked because their other illnesses often take top priority. There's also a deep-rooted misconception in our society that an inevitable part of aging is getting sadder and lonelier. But older adults living out their senior years with mental health conditions often suffer needlessly. So what is it like to live and manage a mental illness in your senior years? And can you thrive? Call to Mind senior producer Jessica Bari meets a woman in Minnesota.
In Hastings, a town on the Mississippi River south of the Twin Cities, I walk up to a light green house.
Hello.
It's so good to see you.
Nice to see you. Welcome. Come on in.
Maureen Edstrom greets me and invites me in. We walk into her living room, a bright and colorful space. It's clear Maureen treasures her family and loves photographs.
Pictures everywhere, grandchildren, graduates.
She tells me about her favorite wall.
Something Rick and I put together a few years ago. I said, I've got to have a family wall. So that's the whole group up there in the center. That was our youngest son's wedding. To the left, at the top, is my daughter. And that's her.
It looks like an art gallery. There are about 25 framed family photos. Some of them are portraits, and others capture memories of vacations, holidays, and good times with her late husband, Rick.
That's my husband, Rick.
Yeah.
Yes.
Yeah, cool.
Yes, this is kind of the memory shelf right now.
Yeah. Mm-hmm. Maureen is a mother, a grandmother, and a great-grandmother. She beams as she talks about her family.
Yes. We've got some wrestlers and some softball players, and this is...
Maureen is 74 years old. She's one of the estimated 5 million people in the United States who live with bipolar disorder. Her illness came on when she was almost 40 years old and a working mother.
My life was pretty normal. I had a great childhood, got married, had a daughter, got divorced. I had a career and things were going well. A lot of friends, a lot of family support. So it was a pretty good life.
Maureen explains that her illness emerged slowly and after some difficult life events. She had a divorce and then a long-term relationship that ended.
I kind of lost myself. I was just really concerned about being on my own. I didn't know what I could do, if I could have enough money, if I could be okay, if I could take care of my daughter. And all of a sudden, I started having a lot of anxiety and feeling really uncertain about myself.
Now, to be fair, all of this sounds pretty reasonable, especially after a breakup. But Maureen started to notice other things.
I was missing work. I was in bed a lot. I did have a friend of mine that I had been talking to a lot. And there came a day when she said, you need help. I needed somebody to tell me, although I probably could have figured it out myself.
She checked herself into a mental health center and didn't realize how sick she was until she got there.
I was psychotic. I had delusions, but it was almost like once I got there, my whole brain and my whole body just was broken.
This was the beginning of some difficult times. Maureen was admitted to a hospital mental health ward. Her condition was serious, so she had 12 weeks of ECT, electroconvulsive therapy, which can be effective for people with treatment-resistant mental illness. Maureen also started regular therapy and medication. And slowly, she stabilized.
I started to turn the corner. I started to get my focus back, my concentration, my energy, my wanting to take better care of myself, communication with my family, and then, well, the rest is the long road of recovery.
Maureen spent a few years finding her way through her mental illness. She admits it was frustrating, but she trusted her psychiatrist and dedicated herself to managing bipolar disorder.
Now that I'm feeling better, I just want to keep going forward. It is possible to be happy again. I reconnected with friends and my family, and once they saw that I was kind of coming back to them, they were like ready to do whatever that they could do to help me.
And Maureen's dedication worked. She never had a relapse.
I have been living with and managing bipolar for 35 years. And the biggest reason that I'm here today and talking to you is because I just worked very, very hard.
Now, Maureen is 74 years old and aware of a big birthday coming up.
There's something about turning 60. There's something about turning 70. And then there's 75. Ooh.
Yeah.
What? Doesn't that have an old tone to it?
No. No. Maureen is retired. She's a social person and she likes to stay busy.
A typical day is going out to lunch with a friend. Not every day, but a lot of times. It's just something for me to, get out of the house and stay connected. I have so many hobbies, like on a daily basis. Right now, I'm working on some scrapbooking. And because I have an 18-year-old grandson that's graduating and I have to finish his scrapbook.
In addition to staying connected with friends and family, an important part of successfully managing her bipolar disorder is having regular check-ins with her psychiatrist and taking medication.
To this day, I still take 2 out of the 3 medications that I initially took when I left the hospital. And he always said, you need to stay on that medication. Don't ever stop. Don't miss a day. And I haven't missed a day in 35 years.
But managing medications can be difficult for an older adult, especially if they have other health concerns. For example, Maureen takes blood pressure medication and needs to watch her cholesterol. So a few times a year, she has appointments with her doctors to monitor all the meds that she's taking to make sure they are safely working well together. So far, she's doing fine. Maureen's success in living with bipolar disorder hasn't been without struggle. She's experienced life's usual challenges. She's had losses, career transitions, family changes, and disappointments. Maureen met her second husband, Rick, a few years after her mental illness was stabilized. They raised 4 kids together and were happily married for 30 years. But tragically, this past year, Rick was in a traffic accident and died. Maureen's working through that loss right now.
Hardest time for me is dinner time. We always made dinner together, and that I could be home alone. I could sleep okay and take care of myself. But yeah, boy, that dinner time, that was hard.
In addition to medication and therapy, During challenging times, Maureen digs into what she calls her mental health toolbox. Over the years, she's developed a collection of coping strategies and resources to help her feel steady.
If I have a bad day, and getting back and connecting with people and taking some quiet time, going to grief groups, listening to music. And so you just keep on going. Yeah.
For Call to Mind, I'm Jessica Bari.
74-year-old Maureen Edstrom is a public speaker who also leads workshops for the National Alliance on Mental Illness, Minnesota. You're listening to The Aging Mind, a broadcast special from Call to Mind. I'm Kimberly Adams. Maureen is successfully managing bipolar disorder in her senior years, and getting the right medication has played a big part in her story, along with finding and working with the right mental health providers. But the American Psychological Association reports only about 1% of psychologists specialize in treating geriatric patients. We talked to one of them. Dr. Doug Lane is a geriatric psychologist based in Tacoma, Washington, and is a clinical professor at the University of Washington School of Medicine. Dr. Lane says there are a couple of myths to debunk when it comes to common mental health conditions in older adults.
One is that sort of this notion that aging and that growing older is somehow this idyllic time when we all turn into quaint older people, which is an ageist notion. One of the problems with that is that it obscures the fact that older people do develop mental health issues and need care. The other myth is that, well, of course, growing older means becoming depressed. That's just part of getting older, which is itself another form of ageism and obscures the fact that older people generally are not any more prone to have trouble than younger people and can benefit from treatment just as much as younger people can.
What are some of the mental health challenges that are unique to older adults?
I've not seen any diagnoses per se in older people that I haven't seen in younger people. But I think the thing that has stood out to me is the way that older people go about addressing those mental health concerns and thinking about them, and especially the aspect of our mental health that is existential, I think is very different and can be in older people versus younger people. I love the notion of our relationship with time, and that when we're younger, we have a particular relationship with time. You know, we're 20, 30, 40, and we have time ahead of us, and that influences how we think about our purpose, how we go about enduring challenges, how we go about navigating the crises and the things that life brings us. When we're 80 and we have less time ahead of us, that requires a renegotiation of that relationship with time. And now the things that are meaningful to us, the ways that we cope, the ways that we find purpose, all of those things are different. And so as we age and especially reach those later years, 80s and 90s, we do begin to develop this relationship that emerges with the days that have gone by. Now it's not just about my tomorrows and how do I relate to my tomorrows. It's also more and more about how do I relate to my yesterdays.
How do other mental health conditions present differently in older adults compared to younger patients?
The physical manifestations can be more prominent in older people. It's one reason that it's not uncommon for an older person to present to their primary care provider first, because they may not recognize that there's a depression brewing, for example, or an anxiety disorder brewing. Presenting in terms of physical symptoms, often exacerbation of already existing physical symptoms. So, for example, the pain from arthritis. There are some mental health conditions which, especially significant depression, which can present with pseudocognitive symptoms. So it's possible for someone who is significantly enough depressed to have notable trouble with memory. And so a very common referral for an older person I've seen over the years many times has been, is this person experiencing a significant period of depression, Or is there a cognitive disorder? Sometimes it's not one or the other, it's both. It's something physical, it's something emotional, or all together.
What are some of the extra things you have to take into consideration when you're diagnosing an older adult with a mental health condition and the best way to treat it?
Probably the number one is their medical status. So any number of medical conditions can serve as what are referred to sometimes as medical mimics. So these are medical syndromes, the symptoms of which can mimic a mental health condition. A classic example of that would be hypothyroidism, which can present with symptoms that might suggest, in some ways, a primary major depressive episode, but needs to be treated differently than we might if it were a primary major depressive episode. Certain medications, especially if there's more than one or two, can create symptoms that appear depressive or cognitive in nature.
How effective are treatments like medications for an older adult compared to a younger patient?
They're just as effective. There's another myth out there that these things don't help older people, but medications, and there's some certainly good evidence-based psychotherapies and approaches to psychotherapy that are nicely effective for older people treating mental health conditions.
As a geriatric psychologist, Dr. Doug Lane doesn't prescribe medications. He refers patients to a psychiatrist or a primary care physician. Ideally, they work together as part of a care team, making sure different medications and treatments work safely together. This kind of care can take more management and appointments, but it can also make all the difference in helping an older person live and feel better. I asked Dr. Lane what he says to people who wonder if it's even worth it to treat a mental health condition later in a person's life.
Go for it. Don't hesitate, because worst case scenario is you feel 15% better instead of 100% better. Best case scenario is you feel 100% better. If I can suffer for the rest of my life, or I can still be uncomfortable but be 15% less uncomfortable for the rest of my life, I want the latter, because that's going to allow me to live these last days better than I would have otherwise.
That's Dr. Doug Lane, a geriatric psychologist in Tacoma, Washington. You're listening to The Aging Mind, a broadcast special from Call to Mind. I'm Kimberly Adams.
This is WMNF
Many
Tampa.
older adults with serious mental illnesses end up landing in nursing homes. And advocates say this is a bad idea because it denies patients the level of treatment and support they would otherwise get in facilities that specialize in mental health care. In Massachusetts, a class action lawsuit is forcing the Commonwealth to invest $1 billion over the coming years to move people out of nursing homes and into community-based housing. Reporter Rachel Rock brings us the story from Boston.
Oh, this is pretty. Did you make that, or did someone buy that?
No, I bought that in an antique store. My grandmother did that painting, and that one over there. They were done in 1901.
Carol shows me her bedroom and the shared kitchen and dining room in a group home north of the city. Getting a room here took Carol a long time. A mental health crisis landed her in a psychiatric hospital and then a nursing home. Carol lived in that nursing home for 3 years against her wishes. She had to wait while her state-appointed guardian searched for a placement that would reintegrate her back into the community. The 69-year-old recalls how it started and how badly it made her feel.
The psychiatrist put me into the system, and that ruined it, rotted my whole life. When you live with a bunch of ugly old people, you really begin to feel ugly and old. You know, nobody noticed me. I was passed by and passed up so many times, you know.
Carol was one of a fast-growing cohort of older Americans with serious mental illness living in nursing homes, places where the primary mission is to care for people with complex medical conditions. Nursing homes generally care for people who don't need to be in the hospital, but can't live at home. Nurses and nursing aides are on site 24 hours a day. Our colleagues at the APM Research Lab analyzed recent data from the Federal Centers for Medicare and Medicaid Services. They found that in 2022, some 62% of nursing home residents over 65 years old were diagnosed with a serious mental illness. That's nearly 600,000 people. And with the aging baby boomer population, that number is expected to grow.
The number of older adults with serious mental illness is higher than it ever has been. Community-based services have not really been able to accommodate that.
Evan Pliss is a geriatric clinical psychologist at Massachusetts General Hospital and an assistant professor of psychology at Harvard University.
It's easier to send somebody to a nursing home than it is to, provide services in the community because they're complex.
Examples of complex mental health conditions, typically referred to as serious mental illnesses, include bipolar disorder, schizophrenia, major depression, psychotic disorders, and more. Managing the behaviors of this population can be demanding. Treatment includes medication management by contract nurses and social supports provided by staff social workers. But robust behavioral support is often the missing piece in nursing homes.
And so the case management needs are so high that very few social workers, even if they have a clinical background in nursing homes, are able to provide behavioral health services.
Instead, many nursing homes rely on mental health clinicians who visit the facility but don't work there full time. And these clinicians can often make more money in private practice.
To do behavioral health really, really well in nursing homes, clinicians really need to be embedded in that space, and there's not enough clinicians. It's not a lucrative model for behavioral health professionals, and so it's really dominated by consultations.
Alice Bonner is a geriatric nurse practitioner who's worked in nursing homes across Massachusetts for 3 decades. She's also worked in healthcare policy at the state and federal levels. Bonner says in nursing homes, too few of the staff people have the needed training to care for patients with serious mental illness, or SMIs.
Because it's not something people get taught for the most part. If you haven't really worked with individuals who are living with SMI, it's a totally different set of principles and things you need to know and learn and figure out how to manage and co-manage.
Despite the significant challenges of funding and staff training, Bonner believes some nursing homes can care for individuals with serious mental illness. In some parts of the country, specific nursing facilities have developed an expertise in this area.
It allows the nursing home to selectively take in older people who do have SMI, and then you get a whole cohort of folks, and then you can support the training of your staff, your team.
Advocates for mentally ill people say the alternative to nursing homes is to invest in community-based housing options. The Massachusetts class action lawsuit, Marsters versus Healy, is helping make that happen. The lead attorney for the plaintiffs, Stephen Schwartz, says Massachusetts essentially has all the support services that older adults with serious mental illness need to live in the community. But because those supports are fragmented across agencies and buildings, they are difficult to access for people who end up in nursing homes. Said another way, the door into the nursing home is large and easy to open. Finding a way out requires slipping through a series of narrow corridors.
And what Marsters was all about was saying that the community system where people want to live, can live, for the most part, should be as disability blind as the institution. And so we were trying to, for older adults with serious mental illness, not have their care defined by their serious mental illness or by their age.
Stephen Schwartz wants states to connect their existing mental health programs with the other adult services already available, like Meals on Wheels, visiting nurses, and supported housing. The Marsters decision in Massachusetts requires the Commonwealth to spend $1 billion over the next 8 years to bring people home from nursing facilities. Carol was one of the 5 plaintiffs suing Massachusetts and who we met in her group home. She now has access to a kitchen, eats most of her meals with other residents, and feels much less isolated.
I figure I'm in a group home. I live, all for one for all, or something like that. I just really care about people. I've learned that's the only way there is.
For Call to Mind, I'm Rachel Rock in Boston.
We're going to take a break, and when we come back, we'll hear about mental health challenges for the people who take care of older adults. That's coming up on The Aging Mind, a Call to Mind special from American Public Media.
This is WMNF Tampa.
Welcome back to The Aging Mind, a broadcast special from Call to Mind, American Public Media's initiative to foster new conversations about mental health. I'm Kimberly Adams. As we mentioned earlier in the hour, there's an extremely small number of mental health providers who specialize in treating older adults. Just 1% of practicing psychologists are certified to treat geriatric patients, and it's similar for psychiatrists. As a result, many older folks end up turning to primary care doctors to get the mental health support they need, or care systems not always qualified to support older adults with mental illness. So how does all this take a toll on the well-being of the people on the front lines of professional caregiving? Some of them are called direct care workers, a tough job with low wages, high job turnover, and work that's often stressful. And because more Americans are living longer, there's an increased demand for some kind of long-term care. The direct care workforce routinely helps older folks manage all kinds of conditions, including their mental health. Chris Farrell brings us this story.
What you gonna want for breakfast this morning, Jay?
For breakfast, 1 egg, 2 eggs, 1 toast, and 4 sausages.
All right, got it.
Deborah Housey is a professional caregiver. She has been working with Jay Spica for 14 years. Jay has severe multiple sclerosis.
You're welcome.
Jay decides to take a shower before breakfast. Deborah heads to the kitchen to prep the meal. And then it's time to help Jay with his shower.
Yeah, we're ready whenever you are.
Okay, just here I come. Got your rag?
Yep. Yeah, I ordered some loofahs. Those are coming soon.
What is that?
One of those puff balls you use to wash yourself with.
Jay uses his walker to get to the couch in his apartment in St. Paul, Minnesota. He deeply appreciates the help he gets from 4 professional caregivers, including Deborah. He makes sure they feel welcome.
I always have something cold to drink. I always have coffee. I always have chocolate. I always try to make things as comfortable as possible.
Deborah has had a long, varied career in the caregiving business, including in private homes, nursing homes, and hospice care. She's also
grandmother, a great-grandmother, and I am an asset to my community.
And she's been a big asset to her clients.
Love taking care of people, taking care of them, washing them, feeding them. It's just a passion in my life that I like to do.
Direct care workers assist older people and people with disabilities who need help with basic everyday tasks. Things like bathing, getting dressed, cleaning, cooking, and taking medications. The work is done in private homes, nursing homes, group homes, and assisted living complexes. There are about 5 million direct care workers. Deborah is experienced and proud of what she does, but the job also takes its toll.
It's very mentally stressful when you take care of others and you don't take care of yourself. I have gone to work plenty of times sick, hurt. I have arthritis myself. My legs, my knees hurt, but I'm still yet there for people. But it is mentally draining because you go home with the people in your thoughts. Are they being taken care of?
Professional caregivers often neglect their own well-being while caring for others.
It's an exhausting job, especially when you leave your children home alone a whole lot and trusting in other people to take care of them. You, in the end, and I'm 67 years old, and I go back and I think about the things that I could have did with my children. I didn't do. Why? Because I was at work all of the time.
Jay says he appreciates the dedication and care.
We need to understand they're underpaid. They're underinsured, but they're doing it because they love doing it. And in many cases, they love you. And people need to realize that. I think that's important.
Important, yet poorly paid. The median wage for all direct care workers is just $16 an hour. Benefits are far from widespread. Nearly half rely on some kind of public assistance, especially Medicaid. Job turnover is high.
There is a body of research showing that significant percentages of direct care workers experience anxiety, depression, a range of mental health issues. Severe burnout is another example.
Robert Espinoza is Chief Executive Officer of the National Skills Coalition, which advocates for better job training.
The job itself is quite demanding physically and emotionally, but also because the jobs themselves are poor in quality. They don't offer good training or advancement opportunities. And combined, this means that they struggle in many ways with their mental health.
The low-wage workforce is largely invisible within the healthcare industry since it's mostly middle-aged women and older, people of color, and immigrants.
This is a workforce that even when they do have health insurance, right, they don't always have the time or ability to access healthcare providers.
Dr. Madeline Sterling of Weill Cornell Medicine in New York City heads an initiative on professional home care work.
They're trying to string together shifts of work, trying to make ends meet. Wages are dismal. And so you just have sort of this setup of a really tough job layered onto a lack of standard resources that someone might access care.
Sterling's research is sobering. One study found that 1 in 5 home health workers said they experienced poor mental health, including anxiety and depression. That's about double the experience of the typical American worker. In addition, about 14% said they had poor physical health, a figure significantly greater than the general population. Robert Espinoza of the National Skills Coalition argues for much greater investments in mental health support. That includes health insurance coverage.
The other piece is that we should prioritize policies that elevate this job into a true profession that's properly valued for the critical supports they offer, right? I mean, these are workers that every day are ensuring that older people and people with disabilities can make it through the day.
Cornell University's Madeline Sterling is working with 1199 SEIU Training and Education Fund, a labor and management fund of the large healthcare union, to conduct the first clinical trial to improve the mental health of home health aides. Workers will receive education, and half will be paired with a peer coach to help set goals and manage difficult situations. The study wants to see if peer support improves the mental health and well-being of participants. Employers can also make a big difference. A nonprofit organization with some 4,000 employees in Minnesota is called Ecumen. It offers senior housing and health services. The strains its workers dealt with during the COVID years push management to devote more resources into the mental health care of its workers.
How do we look at our people so that they get the support that they need at the time that they need it?
Melanie Sullivan is Chief People Officer at Ecumen. Like many large organizations, the company offers its employees benefits and employee support groups focus on mental health concerns. Ecumen is getting more people, including Sullivan, certified as mental health first aiders. These employees are equipped to provide initial support and guidance to colleagues experiencing mental health concerns. Sullivan says, taken together, the idea is to change the language at work about mental health, to eliminate mental health stigmas, and to foster an environment of mental health support.
And when you start to change a culture, you create a sense of purpose and a sense of belonging where it's safe, where you feel like you can talk about the things that sometimes you haven't been able to talk about in the past. We're at the very beginning part of that journey.
Research shows that a connected community is good for mental health. Just ask Ellie Staley, a resident assistant at an Ecumen facility in Minneapolis. Staley, a senior at the University of Minnesota, is passionate about the work.
The residents are the reason why I love the job. I just love connecting and hearing all their stories.
Labor shortages are a troublesome issue in senior living facilities. The scarcity of workers has worsened in the tight labor market of the post-pandemic economy. Ellie deals with the stress with activities like exercise. She has her schoolwork, and she gets much needed informal support from colleagues.
I feel like if there are times where you need to step back, you have your coworkers who understand it more than anyone else, so they are willing to step in. I feel really connected with my coworkers for sure.
Industry experts agree that there is no simple policy wand to wield that will quickly improve the well-being of direct care workers. Progress is slow, especially on the compensation side of the well-being equation. For instance, Deborah Housey, the professional caregiver we met earlier, is on the leadership team at SEIU Healthcare Minnesota. The union negotiated a 31% minimum wage increase to $20 an hour. While Deborah earns $21 an hour, she says it's still stressful to get by.
We should be making $30 an hour. We should be having health care. We should be having retirement. Why we got to fight for all this kind of stuff?
In the meantime, when people are socially isolated, they're at risk of anxiety and depression. That's why more researchers and advocates are pushing for initiatives that foster a greater sense of community and respect for care workers. And speaking of connections, it's obvious that Jay and Deborah care for one another.
Okay? Yeah.
Jay Spica is sitting on a couch in his apartment in St. Paul, Minnesota. Deborah suggests he go through a pile of mail. He starts looking at it.
I can look at the census stuff.
You gonna come to the table to eat today, or you gonna eat in there?
You know what? It would be better if I could eat in here. Is that okay? Or do you want me to come to the table?
This is what I want to say. You've been eating in there a whole lot, but you should be eating at the table because it's more safer. Okay? And then we ain't got to worry about the rug and all that kind of stuff.
Deborah Housey is a caregiver to Jay Spica in St. Paul, Minnesota. For Call to Mind, I'm Chris Farrell.
You're listening to The Aging Mind, a broadcast special from Call to Mind. I'm Kimberly Adams. A note to our listeners, this next conversation discusses suicide, so please take care as you listen. And if you need support, call or text 988 to be connected to a counselor. Untreated mental health conditions in older adults can, in the worst cases, become deadly. The Federal Centers for Disease Control and Prevention reports that suicide rates among older folks have had a disturbing uptick in recent years, even as rates for younger groups have gone down. Older men are the most at risk. Dr. Yates Conwell is a geriatric psychiatrist at the University of Rochester Medical Center in New York and a past president of the American Foundation for Suicide Prevention. Dr. Conwell says high rates of loneliness and isolation in the United States might be contributing factors to increased deaths by suicide, but they're not the only reason.
Being connected to other people is really a necessity. It's kind of like the air we breathe and the water we drink. And absent those connections, people can become at greater risk for suicide. Older people are, in a way, particularly prone to that condition because of changes of all sorts. So older men, retirement. Men often have defined themselves and their worth in terms of their jobs. Also, bereavement or other losses of family and friends is a powerful means of disconnectedness. Physical illness, if there is disability or, let's say, vision, hearing problems, or being able comfortably to socialize with others. So there are a lot of different drivers of loneliness in later life that are a little bit distinct, but still provide increased risk for suicide in that age group.
Some people might hear all of this and get the sense that older adults are generally sad and in distress. But what do you actually see in your practice?
That is probably one of the most important things for people to realize, that older people do, in general, very well. They're survivors. They've been through a lot and they've learned a lot. So the idea that old age is a time of deficit and sadness is really overdone. We all face problems, but we also all, in later life, have encountered challenges before and have a deep well of resources to draw on.
You've put together a framework called the 5 Ds of suicide risk in older adults. What are those 5 Ds?
So the 5 Ds are depression, disease, disability, disconnectedness, and then deadly means, which in the U.S. typically means access to firearms or other means to end one's life that have a high lethality. Depression is a high prevalence, very painful condition that is associated with suicide. Many people experience depression kind of with a small d, depressed mood. Oftentimes that's transient and in response to challenges we face day to day. But it's when that depression becomes a clinical disorder for which we have good treatments that it is more associated with increased risk. And that increase is substantial. The second D is disease or physical illness. And the issue there is that those illnesses, of course, are that much more common in older adults. And then also disability, which is that third D. If somebody is physically ill and it causes functional impairment, for example, following a stroke, which leaves somebody unable to do the things that they most enjoy doing, then functional impairment becomes another driver of suicide in later life. And then the last D is deadly means. And in the U.S., that's firearms.
So some of these Ds, especially depression, disease, and disability, can be pretty huge factors in a person's life and are often something an older adult will live with for the rest of their life. So what are some actionable ways to help someone who's dealing with these things or maybe even seems to have some suicidal thoughts?
So, for example, on the depression side, we have good treatments, including in older people, and they include psychosocial interventions, talk therapies, as well as medications. Those are all available if somebody has access to the care that they need. There's models of collaborative care or integrated care where there's a mental health provider in the primary care doctor's office or suite, allowing a warm handoff when the doctor says, there's a person here I'd like you to talk to. So access and acceptability, and that's true also for the D for disease. Effective diagnosis, access to care, therapies, occupational, physical, other kinds of social interventions that optimize independent function, even in the face of those ongoing limitations that often come with age.
So how can we better listen to older adults who might be struggling with their mental health?
Part of what we need to do is just learn how to ask the question, how are you feeling? And to open up a discussion that is in and of itself a tremendously healing interaction. Simply knowing that there's somebody there that is strong enough and committed and interested to hear about my pain is a very supportive intervention that can change that balance, that ambivalence very quickly.
In addition to looking for the 5 Ds, depression, disease, disability, disconnectedness, and deadly means, Dr. Yates Conwell says if a society did a better job recognizing the value of older adults, that would do a lot to prevent suicide.
One of the most important things we need to be doing is to recognize that a lot of good can be had and suicide deaths reduced by moving upstream. That is, if we can have in place systems that assure access to care, if we can have acceptable means for older people to live independently while also providing them with a role to define their lives as older people having worth. Upstream meaning things like integrated care environments, of making transportation available, of doing screening when people are anticipating change in their lives that they might need some help negotiating before they become crises. So the upstream preventive approach is just as important, perhaps more so than just the response to the crisis.
That was Dr. Yates Conwell, a geriatric psychiatrist at the University of Rochester Medical Center. You're listening to The Aging Mind, a broadcast special from Call to Mind. I'm Kimberly Adams. We've heard that the stakes are high for untreated mental illness in older people, and there are many reasons older folks don't get the mental health care they need. Access to qualified treatment is often limited, other health concerns get prioritized over mental illness, and ageism plays a big role in these problems getting overlooked. So where are the real solutions? If support through a nearby hospital or clinic isn't an option, where can older adults find the services they need? And how can they live well? We go next to Georgia, just south of Atlanta, in Clayton County, Georgia, where there's an active network of 5 senior centers. Each one offers unique services, from aquatics to dance classes, wellness resources, and social activities. We visit the Sana Singleton Gregory Senior Center at lunchtime as a group of people sit down to have a meal together.
I'll take potato salad and the carrots. Hello.
Tori Strotter-Tanks is at the center today.
Good to see you. How things been?
She's the director of senior services in the county and oversees the 5 centers.
How's it been this morning?
Tori is a big advocate of these centers. She says they play a vital role combating loneliness and improving an older person's well-being.
Most people, when they think about a senior center, their minds automatically go to bingo and crocheting. And while we offer some of those services, a healthy senior center is where seniors come to get engaged. They can take classes. They can learn how to swim. They can just hang out with their friends. They can go to really cool dances. They can travel. We have stories of seniors who have met and found love and gotten married because they met at the senior center. So that part of the aging process is just absolutely wonderful. And if you can do that in an environment like a senior center, that's just like one of the best kept secrets to keep people and seniors healthy, active, and engaged.
We hear so much about the epidemic of loneliness in this country. What role do you think senior centers play in stepping into that problem?
It may not be the panacea for ending senior isolation, but it is high up there on the chart, in my opinion. In senior centers, you can get social connection, physical activity, cognitive stimulation. You can find purpose and empowerment. All of these things combat isolation and loneliness, especially that social connection. It is really good for people to be around other people, people of like minds, people of all ages and cultures. All of that is found in a senior center.
So tell us about the senior center model in Clayton County, Georgia. How many centers do you have and how do they work?
We have 3 senior centers and 2 intergenerational centers. All of them have a different vibe and a different feel. So you may go into one of our senior centers and it's a transient senior center. People are coming in, they're taking classes, they may stop in and get a meal and then they leave. You may go to another one of our senior centers and they come and they stay all day. They're there, they're playing cards, they're meeting with their friends, they're enjoying breakfast, they're enjoying lunch. They may go to a doctor's appointment and then come back and catch a quick card game. So here in Clayton, our senior centers are very affordable. If you live in Clayton County, it's only $12 a month just for your basic membership. We have low cost and affordable breakfast. Breakfast is about $4.50 for a full breakfast. Lunch is right at $5.50. And our county supplements all of these services.
You mentioned intergenerational centers. What are those?
In Clayton, we have 2 intergenerational centers. One is Kinship Care Resource Center, and that is for grandparents who are raising their grandchildren or relatives who are raising children in parent-absent homes. We provide support services like after-school help. We do summer camps. We do support groups for those grandparents. We also have our Flint River Community Center, and it's basically kind of like a recreation center. However, the main population that we focus on is our seniors that come to that center. It has a black box theater. It has a full gym. It has a fitness center. It has a Boys and Girls Club attached to it. When you walk in there, you're going to see all generations participating in activities together.
I probably don't have to tell you this, but the number of psychologists and psychiatrists working specifically with older folks is very, very small in the United States. And oftentimes seniors aren't getting the mental health support they need. Where do you think the kind of programs you're providing at these senior centers fit in?
We may not do like mental health coaching or counseling ourselves, but we have information and referral specialists that help our seniors point and navigate them to resources that can help them if they're having any kind of mental health challenge. We partner closely with our health department. We partner closely with our local doctor offices and hospitals. Here in Clayton County, our hospital has a whole wing now that focuses on mental health challenges amongst the senior population. So we do a lot of coordinating and collaborating when we have seniors that have mental health challenges. So our staff is trained to be able to connect those seniors with the resources.
In March, Tori Straughter-Tanks testified to the United States Senate's Special Committee on Aging about ways senior centers can break the cycle of loneliness. One of the issues she touched on was how much money senior centers can actually save a community.
Falls is the number one thing that causes serious issues amongst the senior population. As we age and a senior has a fall, they could go into the hospital, and sometimes seniors do not recover from that. Nursing homes cost our economy and our country billions of dollars each year. So if you come to a senior center and you're engaged in fall prevention and evidence-based classes that help you manage chronic disease, classes that help you with diabetes and manage your blood pressure, this is an empowerment that's keeping you out of hospitals, it's keeping you independent in your home, and is actually engaging the community and helping our seniors become stronger. So senior centers really do save our county and our economy billions of dollars just from the health benefits alone.
Given the mental health care shortage in the United States, especially for folks focused on older adults, how important do you see the role of senior centers, especially as our aging population expands?
I think senior centers are going to play a vital role. I mean, people are going to constantly get older. We have to be prepared to have things to help people engage healthy, help people engage actively. That's just something that we're going to have to figure out. And for me, instead of trying to figure out and reinvent the mold, invest in senior centers. Give senior centers the support that they need to make sure that seniors can remain active and well. So it has to be a huge concern that we all address and attack because senior centers are extremely important.
That was Tori Strotter-Tanks, the Director of Senior Services in Clayton County, Georgia, just south of Atlanta. The U.S. healthcare system for older adults ranks pretty poorly when compared to many other developed nations. A report by the healthcare research nonprofit the Commonwealth Fund finds that older Americans are sicker and face more financial burdens to healthcare when compared to people their age in other countries. Older folks in the United States also spend more time alone compared to anywhere else in the world. It's much more common for older people to live with extended family in Latin American and Asian countries versus here in the U.S., where living with a spouse followed by living alone is the most common arrangement. Dr. Doug Lane, who we heard from earlier, says there's a lot of room for improvement in how Americans care for the people aging in our communities and families. And he offers one brief and simple solution.
Hang out with older people. We know this. They know some stuff that we don't get to know yet because we haven't lived long enough. 95% just like us, because in the end, we're all human beings. Find out what they think. Recognize that they have something to offer and that we're a lot more like them than we're different.
You've been listening to The Aging Mind, a broadcast special from Call to Mind, American Public Media's initiative to foster new conversations about mental health. This program was produced and written by our senior producer, Jessica Bari, and edited by Stephen Smith. Our technical director is Alex Simpson. And Chris Julin scored the show. Matthew Alvarez, Annika Best, Nikhil Kumaran, and Claire Reynolds provided production support. And this show was hosted by me, Kimberly Adams. To find resources and all of our past programs, visit our website at calltomindnow.org. Thank you for joining us for The Aging Mind, a broadcast special by Call to Mind from American Public Media.
Hey, this is Sue Foley, and you are listening to WMNF.
Well, thank you, Sue, for that legal ID. You are listening to WMNF Tampa. Sue Foley was one of the headliners at WMNF's Tropical Heat Wave on Saturday. I hope you enjoyed it. And thanks to Blanny for recording that legal ID for us. This has been WMNF's Tuesday Cafe. I'm Sean Canan. If you missed any of this show, or if you'd like to share it with a friend, you can listen on WMNF.org. It's up there right now. If you go to WMNF.org, you can share this show with a friend if you enjoyed it. So you can also listen again on WMNF.org. In this time slot at 10 o'clock tomorrow morning is Midpoint. Coming up next, we're going to hear Winona LaDuke talk about the rights of nature. Then at noon is an episode of Wide Awake America, where Emmy-winning comedian and cultural critic W. Kamau Bell joins host Nadine Smith for an unforgettable conversation about the power of humor to expose hypocrisy, bridge divides, or burn it all down when necessary. From sit-downs with the Klan to the viral fallout of We Need to Talk About Cosby, Kamau reflects on his evolution as a comic, activist, and father in a country where laughter can be an armor and a weapon. They tackle cancel culture myths, the rising stakes for black families, and why sometimes the best use of your time is not debating MAGA uncles, but standing with your vulnerable neighbors. So that's all coming up at noon on Wide Awake America, hosted by Nadine Smith. At 1 o'clock is The Scoop, WMNF's 5-minute summary of the day's news. This has been Tuesday Cafe, coming to you from the studios of WMNF Tampa, St. Petersburg, Sarasota, and Lakeland.